had the males, we had the females, and I broke them out in categories because sometimes it's good just to look at what are we looking at. The average age for males was 63. The average age for females were 69. Now, what brought the males down was because you had one male that was 33. Okay? Now, you take a look at the females here. Now, we have females clustering in the age of 15, 15 in the 35 to 65 bracket. Then you have females 66 to 75, 77 to 85, and then you have more in 85 older. Well, we do know that women, we live older than men. Okay? And here in the 35 to 65-year-old bracket. This is interesting, but it correlates to the data that's in the research. So I'm going to do a little quiz for the audience. In this age bracket, let's think back for some of us who might be a little bit older than some of the other ones in the audience. Think back into the liberation in the 70s, you know, when women were being liberated. There was a marketing ad for cigarette smoking. Okay? Because remember I said 40% of the reason people smoke, there was a particular cigarette. Do you remember that ad? Virginia Slims. It says, you've come a long way, baby. So what? Geared specifically to get women to smoke. And you can see, women started smoking, and you have women now reaping the adverse benefits of smoking. Correlation is there in the data. Okay. So it helps when you start for the staff. Now you're starting, and they're seeing it. I see their heads nodding. Okay. The other data I looked at was review of the attending physicians. Now these are not the physicians because we have a lot of hospitalists here, but these are the docs that they go home to. And when Susan and I had the opportunity to take a quick look at this data, Susan was not the least bit surprised at what doctors that they were going home to that were admitting the patients. And they are familiar with these physicians' names across the bottom line. So this is the number of admissions and then the physicians that they go home to. So we have them across the bottom. And it is how frequently they were admitted for that time period. And this is a beginning trend for the PCR staff to look at their physicians and say, okay, who is bringing them back in? Now, it's not the hospitalist, which would be the next step up and say, how many, what are the hospitalists and what do we see? But you can see here the patients and the physicians. Now, what we can look at is the inconsistency of how we're bringing them back in, what's happening with them, is there an inconsistency of how they're discharging them, what's happening with them. The other thing is, I just looked here to see, was there any trend? I can't give you a trend for 1 month. There's no way. I'm not going to say, he's a bad doctor, or he's a very good doctor. However, so no trend is what I'm going to have to say. Down here, out of the 62 visits, 4 visits were NA. You took the time, nurse care managers, to review 4 charts, and there was no need for you to review them. That is something, though, Susan wanted to know because she does a productivity review. And so you are looking at patients that, for some reason, you got triggered to review them, but there were no COPD patients. And I do believe, I think, Sharon, it was you that did do a very nice review, but when you got there, they were not COPD patients. The next thing I did is, out of those, I looked at the patients that were readmitted, because that is the core of what we do. Look at your readmission. Okay. Now, I split them out because the essence of what I was doing in the practicum was looking at COPD readmissions. Okay? So I separated the terms in COPD. You had 4 patients that were readmitted with COPD. Age and sex, physician, diagnosis, this admission, which would have been your July readmission, and then diagnosis of the prior admission. So what were they admitted for the first 30 days within that window? What did they come back in? What physician are we seeing? And whatever. This 81-year-old man, he was seen twice, so each visit is considered a separate visit. So he came in twice in the month of July, and you would know this gentleman's name. Okay, so is there a trend? You might, because now you can go back and say, oh, I did see that physician's initial, so you might have some conversation, good dialogue saying, okay, I'm starting to see a trend. Okay, age, you can see that that is older population there, and those are your COPD. So you had 4 out of the, if you take the 4 out of the 66, you're now down to 62, and you can calculate your percentage. So that is your readmissions for the month. Again, just a tiny, tiny snapshot to say where you're going. Down here now were the rest of your readmissions for that month period. Again, this is everybody, because now the PCRC is looking at the whole group because you picked up any readmissions. Okay, what they came in for, what they were admitted for the prior 30 day. Came in with EKG changes, they had bronchitis before. Transferred in from Shadyside, they had a hip replacement elsewhere. I see heads not go, and you remember this. This would have been the same readmission because it's CHF. I was not looking at that because not within my scope. Diabetes, same readmission. EKG changes, but they had bronchitis before, and that's why you all picked them up. Changes, this is the same one, and then multiple diagnoses and bladder cancer. So it starts giving you a sense of what you're looking at and what you're seeing. So it can help you say, all right, if this is done periodically, you can also say, all right, now I'm seeing what I'm looking at. What else? You cannot be looking at data without getting a sense of other data points or review points. So part of looking at that, and part of my objectives were saying, what else do you see? Are you getting that flow of information with other interdisciplinary groups? So I was looking to say, what else do I see? Are they using the IPOC? The IPOC is the interdisciplinary plan of care that lets other disciplinaries within the hospital know what's going on. So I looked at that. Are you doing the red flags? Are you looking at smoking cessation? Are you doing everything else? So, readmissions, following up, smoking history, emergency flags. So you saw 66 patients, which I think is a tremendous load. 41 of your patients agreed in some format to stay with you, and I think that is really a great effort. So you are really making contact. The personalities are there. You're meshing. They see the need in your service. So that's great. That's a 66% retention rate. Average of patients seen per day by your staff is 5. Okay, so that's a lot of work going out and doing it. Time spent with patient, you're calculating is like 15 to 20 minutes. Now, I cannot tell you how much time your review process in the morning. I saw what you were doing, but there was no way I could sit there and say, all right, this is how long. But the time that you're spending in dialogue at patient's bedside is your time there. So if you're going back to what CMS is asking, is this program doing? Is it looking at the objectives I set forth? I'd say they're meeting the goals and they're making a difference. Now, in every program, you have to say, how did you collect the data? Well, thanks to IT and Alberta Guide, which Susan had worked with them, they have a PCRC care manager checklist. And this is where I went to check their documentation, and their documentation was phenomenal. Kara has her own tool, and her own tool is in place. Okay. The other thing that was developed was a performance improvement plan with the scope of care. And in the scope of care, we came up with their plan, do, study, check. It's a little bit different than what we normally do, but what they're doing is going to be doing, and it's called the Deming's approach, or it is called rapid response change. And I think everybody here has been familiar enough with Toyota change to know this is what they'll be doing. You have a lot of responsibility out there. Your plan is your scope of care, and that's what you have been given. Your do is you've got your indicators. Your indicators are your huddles. You know how you get your huddle list of your readmits. You're going to look at your readmits. You're going to go out and you are going to take your readmits and say, okay, we're all here. We're going to work. We're going to change. If you get your interdisciplinary people together, what did happen before? What's happening now? What can we do to make a difference? Your threshold has been set at 95%. That means you don't have to do 100%. But I know you're obsessive compulsive people, you'll be at 100%. That was one indicator. Second indicator was peer-reviewed documentation. Why? Because you're documenting off two different systems. So while you are growing, Susan wants to make sure that you're documenting appropriately to make sure everything's in place. That was your second indicator. Act, intervene when the processes are not at a threshold, significant events occur. So what's going to happen? She wants to make sure that between the quarterly review, that you make sure that as you're reviewing each other, you stop, you check, and make sure everything's okay. So you're going to do plan, do, study, check, and that's why quarterly you've got thresholds, and you're going to intervene. Okay? And you're all familiar with PI, so I know that you will do a great job. As a student, and as I put my student role on, one of the requirements I had to do was, what did I learn in this master's program? What kind of leadership did I see? And they give you different roles, and they say, pick a role, pick a leadership, and see which one you think fits. So, and I think that was probably my hardest one. But once it came to me, it was like a light went on. And so I said, I think it was transformational. And let me read this because I think this is so moving. Leadership defined healthcare in change and restructuring. And that's what you all were. And it was Susan, your leader, but since you were all managers, I think it means all of you. Commits people to action, brings people to action, followers to leaders, and leaders to change actions. I think the four of you are change agents, all of you. Transformational leaders empower others to have a vision about the organization, to work to the goals that benefit the organization and themselves. Pause, be proud of yourself. Susan, you've done a great job. The way you took that 8-hour day, and I moved, and you had the white paper up there, and you set up the goals for your team, and you allowed me to participate. That is a true transformational leader. I have given you a list of references. Some of you might want to read more about value health, changes in healthcare, about CMS, about transition and care. If you can, I will make any of my articles available to you. Because after all, I know that we are moving in healthcare, and this is where evidence-based is leading us. But I would be totally remiss if I did not give a big thank you to special people in the audience. Susan, Deb, Sharon, and Carol. And to the other special people in the audience, Kathy, Christopher, and Adela. And now, any questions from my audience? I want to thank you all for being such attentive listeners. And again, thank you for taking time out of your busy schedule to be with me today. You go, girl.